This is the vestibulo-ocular reflex by Isabel, Cheryl, Shayla, William, and Gustavo. All right, so we've got a couple definitions here. We have the definition of VOR and VOR gain. The definition of VOR is a reflex that stabilizes our eyes. It keeps them fixed on our gaze while the head is moving. And VOR gain is defined as the change in eye angle divided by the change in head angle during movement. Basically, that just means the amount of head rotation compared to the amount of eye movement.
The examination for the vestibulo-ocular reflex is known as the head thrust test. The doctor holds the patient's head in his or her hands. The patient looks at the doctor's nose. The doctor will then place the patient's head in 30-degree cervical flexion. The doctor, while looking at the patient's eyes, oscillates the head back and forth in a horizontal plane and then stops suddenly and unpredictably to one side. Results: a normal response would be patient should be able to maintain the visual fixation, looking at the doctor's nose, when thrusting to the side being tested, and that's known as gaze stability. An abnormal response is an inability for the patient to maintain fixation and corrective saccade is observed. And this would indicate a vestibular lesion. And abnormal VOR functions can result in symptoms such as blurry vision, dizziness and/or nausea, and difficulty maintaining balance with the head movements.
All right, we have a little summary on how it works. I'm going to go over this pathway on the next slide. So here we have the VOR neural arc, and we will use right head rotation in this example. So as the patient turns their head right, it causes the hair cells within the lateral semicircular canal to bend. The hair cells within the left and right lateral semicircular canals will bend in opposite directions, causing an excitatory effect within the lateral semicircular canal on the right and an inhibitory effect within the lateral semicircular canal on the left. So here we have the right lateral semicircular canal sending an excitatory signal to the right vestibular nucleus, and the left lateral semicircular canal sending an inhibitory signal to the left vestibular nucleus. So from the vestibular nuclei, we will have these two neurons crossing over and going to the opposite side abducens nucleus. From the abducens nucleus, it'll send two neurons out. One will go to the same side lateral rectus muscle, and one will cross over to the opposite side reticular formation and continue on to the medial rectus of that side. So here in our example, we have the right abducens nuclei sending inhibitory signals to the right lateral rectus and the left medial rectus, causing them both to relax, while the left abducens nuclei sends excitatory signals to the left lateral rectus and the right medial rectus, causing them to contract. So the net effect we have is the eyes moving to the left as the head moves to the right.
The next part we are going to present is brain or brainstem areas affected. The vestibular information is primarily processed in the brainstem via efferent fibers of the cranial nerve 8. The signals enter the brainstem at the medulla and pons, which is known as the vestibular nuclear complex. The vestibular nuclear complex is comprised of four major nuclei in the floor of the fourth ventricle. Most of the semicircular canal inputs synapse with the superior and medial vestibular nuclei via first-order sensory neurons of the cranial nerve 8, while second-order sensory neurons send signals ipsilaterally and contralaterally via the NLF to the cranial nerve 3, 4, and 6. A third motor neuron excites the extraocular muscles, causing conjugate eye movements that are equal to and opposite of head movements. This results in gaze stabilization during head movements.
The vestibular system is unique in that it also sends collaterals to the cerebellum via the inferior cerebellar peduncle, with a role in modulating or fine-tuning the VOR. More specifically, the flocculonodular lobe and fastigial nuclei regulate vestibular and oculomotor function. The cerebellum is also considered the adaptive processor of vestibular information, specifically as related to error messages, and assists in coordination, maintaining posture, and modulation of vestibular reflexes. There are additional vestibular connections to the thalamus, cerebral cortex, and reticular formation. These extensive connections result in a coordinated effort between the vestibular system and other central networks to contribute to arousal and conscious awareness of the head and body in space.
Now there will be a demonstration of how to test the vestibulo-ocular reflex function.
Hello, we're going to be demonstrating how to perform the head thrust test. For this test, the patient will maintain, we're going to be looking for the patient's ability to maintain fixation on a target. In this case, it'll be my nose. We're going to grasp the patient's head on both sides. We're going to flex their head forward around 30 degrees, and we're going to oscillate side to side so the patient doesn't establish a pattern. And we're going to thrust to one side, and that'll be the side that we're testing. Patient, look directly at my nose. The patient demonstrated a normal response, which means that they were able to maintain fixation on the target, which indicates a negative test. But in case of a patient with a positive test, this was what it would look like. So this test was positive because the patient was unable to maintain fixation on the target and had to establish corrective saccades to maintain fixation.
Now we will be discussing a case involving a patient presenting with hypofunctioning vestibular system. A 58-year-old patient presented to the office with hearing loss and dizziness. He reported to have had cold symptoms 2 weeks ago. He had been using over-the-counter cold medication, which helped relieve the sneezing as well as other cold symptoms. However, last week, the patient started noticing hearing loss in his right ear as well as dizziness. He noticed that reading a book has been requiring greater effort, as small head movements may cause visual distortion. Patient also notices nauseousness when driving since last week. He noticed difficulty in maintaining balance at times. He also reported to have blurry vision randomly throughout the day for the past few days.
For this next section, we will be talking about the examinations we'll be doing on this particular patient. So first of all, we will be doing vital signs and looking for any signs of infection. We will be doing inspection of the eyes, focusing on the eye position and ruling out any possible strabismus. The smooth pursuit test in the 9 cardinal positions of gaze to assess the range of oculomotor control. The smooth pursuit test in the H pattern, which will be testing the cranial nerves 3, 4, and 6, as well as ruling in any pain or dizziness. The saccade test, vergence test, VOR cancellation test, the head thrust test, head shake test, visual acuity test to rule out any pre-existing vision conditions, cranial nerve 8 testing, which would include a Weber's, René's, and Hall-Pike-Dix maneuver, as well as an otoscopic examination to identify any external ear infections or blockage of the ear canal. The examination findings we got for this particular patient were a positive vital sign, as the patient was running a mild fever, The head thrust test was positive as both of the patient's eyes did not maintain fixation on the target when thrusting to the right side. The head shake test was positive as nystagmus was present. Cranial nerve 8 testing was positive, and a few particular tests that we will focus on were the Hallpike-Dix maneuver, Weber and Rhine test, the Hallpike-Dix maneuver, which was positive because the patient had nystagmus after moving and stopping. Weber's was positive as sound was louder on the left, so this would be a positive for sensory neural deafness, and a positive Rhine test as the patient reported absent air conduction and bone conduction on the right side.
So this patient is suspected to have labyrinthitis, specifically viral labyrinthitis. Viral labyrinthitis is relatively common in adults aged 30 to 60, but has yet to be confirmed by a specialist or a general practitioner. It is important to get immediate attention for these patients with this condition, because if the symptoms go ignored for a long time, they can become chronic or even more severe. Risk factors of VOR gain reduction are head injury, aging, or other kinds of infection. In this case, the patient's age and infection resulted in his VOR deficit. Labyrinthitis is when one of the two vestibular nerves of the inner ear becomes inflamed. Therefore, for this patient, the right semicircular canal fails to send the excitatory and inhibitory neurons effectively to the corresponding vestibular nucleus because of the inflammation in the inner ear. So, the neurons cannot cross over to the abducens nucleus and cannot induce the right medial rectus and left lateral rectus muscles to contract effectively. That's why this patient revealed remarkable VOR gain below 1-to-1 ratio in rotation towards the right side. Some associated symptoms of labyrinthitis are hearing loss, cold symptoms, persistent vertigo, which are all tested positive for our patient as well. A mild fever is also a result of this infection. Here's a list of possible treatments for this patient. The patient would perform gaze stabilization exercises 3 to 4 times a day. This exercise is done by having a patient facing a blank wall and holding out their thumb straight in front of them, keeping their eyes fixed on the thumb while turning the head to the right and then to the left in a smooth motion. Each turning motion should last 1 second. This exercise should be performed for approximately 1 to 2 minutes. We can also adjust the patient to help them with their brain, which would in turn help with the vestibular system. And we would also refer out the patient to a GP or otolaryngologist who can prescribe either antibiotics for bacterial labyrinthitis or antihistamines for viral labyrinthitis. For diet modification, we would recommend a low-salt diet for the patient, as excessive sodium intake is known to disrupt vestibular homeostasis. The patient should also maintain anti-inflammatory diet consisting of plenty of water, antioxidants, and micronutrients. Sufficient vitamin B, C, zinc, magnesium can also help restore nerve damage and improve blood circulation, which then reduce inner ear pressure due to fluid buildup. The patient should also avoid fried foods, alcohol, and processed foods, as these are known to trigger vertigo symptoms. The patient should also avoid smoking and avoid activities that trigger vertigo, such as prolonged reading or driving. We would also convey the importance of practicing good hygiene, such as washing hands frequently to prevent infections for the patient. This is the end of our presentation.